NHS service available for veterans in the area. So should we move on to the next slide, Joe? All right, so I guess one of the questions for quite a lot of people has been about how did all of this come about, and what happened in 2016. There was a bit of an engagement document, so they're having a look at what veterans' needs were in terms of the mental health field and trying to work out what some of the barriers were in terms of people being able to access support. So particularly looking at something like PTSD, then at the moment, from the point of trauma to the point at which somebody will come into services, we're looking at an average of about 13 years, which, as you can understand, it's a fair while, and people's mental health will progressively get worse during that time. So NHS England was starting to look at, well, how do we change that? What are some of the barriers to people being able to access help? So they developed this engagement document to have a look at what some of these issues were. And as a result of that, they decided to set up the NHS TILS, which is the Transition Intervention Liaison service, and linked onto that the complex treatment service. And the idea behind these services, we're trying to break down some of these barriers, break down some of the stigma. So understandably, when people are in the military, then some of the barriers towards accepting help at that time might be the impact it has upon somebody's career. It may be about kind of a lack of support. It may even be that at that time people don't even fully understand the difficulties that they're experiencing. So quite a lot of symptoms might be masked by other things. So for example, if somebody has high levels of kind of irritability, then you've got sport, you've got social support, you've got all these outlets to be able to kind of give you a normalized kind of way of working through this anger to get rid of some of this irritation, which aren't always available in civvy streets so much. So I guess so one of the things that the NHS England were trying to think about were, okay, if somebody's then joining from the outside, why they're not coming from the NHS, why we're not seeing so many people through our systems. And certainly going back to 2016 when this was developed, I think a large amount of veterans were dependent upon military charities and a belief that the NHS doesn't necessarily understand the needs of veterans, and particularly when you've got specific services available, for example, combat stress and later Walking with the Wounded as they develop their programmes. So what NHS England wanted to do was to build up a military sensitive service that's kind of reducing the stigma of mental health within veterans, but then also something that could be accessed, closer to somebody's home. So some of these other organisations you could go to, but only on an inpatient admission, and they're quite far away from people's homes. So in terms of working through some of the issues people may have more directly within their area, it became a lot more difficult. So for example, anxiety going to shops, it's a little trickier to work upon that when you're in a completely different area than if you're in your own home environment. So NHS England was trying to think about how we could break down some of those barriers, reducing those engagement opportunities for veterans in the local area with their local mental health system through the NHS. We move on to the next slide, please, Joe. Okay. So the Transition and Liaison service was looking at is a bit of a gateway really around mental health. So anybody can refer to that if they are serving personnel who are due to be discharged. They've got a discharge date and they're looking at transitioning into civilian services, or if they're currently a veteran and experiencing mental health issues. So what TILS will do initially is they will make an assessment with individuals to look at what their particular needs are. And from that, they may be able to do a piece of work with them directly, in which they might look at things like recognising their early warning signs, getting a bit of early intervention support with the mental health difficulties they're experiencing. It may also be around signposting or referring to another appropriate service or services. So for example, it may be that they make a referral over to combat stress, or they make a referral over to the Head Start programme over at Walking with the Wounded. They might refer to a local community mental health team, or they may make a referral over to the complex treatment service. So for us, in terms of the complex treatment service, the TILS is our gateway into our service, but wider, they can provide that assessment and that port of call for any veteran with a mental health problem, that they can make the most appropriate referral to the most appropriate team. I think the issue quite a lot of people have around mental health is they don't really know where to start. So in terms of working out what the problem is and who the most appropriate person to go to, it can all be quite tricky, particularly when you're trying to work through whatever difficulties you're having at that time. So what TIL service will do is they'll assess people and help them understand that, building up a treatment plan with the individual, taking into account what their particular difficulties are, but then also what they suggest, may be particularly helpful. Bearing in mind, we're also appreciative that, quite a lot of the veterans that will come to our service may also have difficulties around things like housing, employment, alcohol use, and social support issues. So when we're looking at mental health, we're not just thinking about mental health as a single thing. So we're not just thinking about anxiety or depression or post-traumatic stress disorder. We'll also be having a look at some of the factors that are playing into that. So it may be that we kind of help link people up with people like SAPA or the Royal British Legion, or they may need a support letter to help them around issues around housing or employment. And so they'll always be trying to think about what your individual needs are, but then also every service that may go into playing a role within that. So it may not necessarily be one service, it may be variety. And what they'll do is they'll sit down and plan it out with you in terms of who you're accessing at what point. Next slide, please, Joe. So the TILS area for us is for the Midlands and East Veteran Service. So we come under the West Midlands. I don't know if you can see that in the purple there. So your local TILS service would be the Midlands and East if you're looking on the Veterans Gateway, or if you're looking on the internet. We've provided at the end of the presentation the referral details for our specific TILS service for you to have a little bit of a look at. But as you can see, it kind of covers quite a fair kind of region. And within that, then our particular service is, so the complex treatment service, we only cover a small area of that. Next slide, please, Joe. Okay,
Yes,
so
that's amazing.
Of course, take over, Joe.
It's okay. I'm happy to stay quiet and listen. That works okay for me at this time in the morning. Yeah. So what is the CTS? So after people pass through TILS, they may get a referral to come and see us. There are 5 CTS services, or CTSs, in the country. As you can see, they're listed up here. They each cover a huge geographical region. I think you saw on the previous slide, the number of different counties and cities which are listed on there are quite wide. So we are based, our service, in the Barbary, which is by the Queen Elizabeth Hospital in Birmingham. However, we tend to be more community based, just because of the amount of land we have to cover. Which is a good thing, because it normally means that we're able to see people a little bit quicker. We're able to adapt if people are unable to leave their houses, or for whatever reason that might be. So the service was commissioned, as you can see, a couple of years ago now. And we do sit alongside mainstream services. So by that, we mean the community mental health teams and the other NHS providers as well. So we're not an or service, we can work hand in hand with some of those mainstream services, and often that's the right way forward. People might have existing relationships with other people who work within the NHS mental health services, and we try and adapt so we can incorporate those relationships. And it's always easier to do something alongside other people if that's more effective. So the point of the CTS, as Suzanne's already mentioned, is to work with military veterans, but also families and carers of those veterans. There's often a wider need, as I'm sure you can all imagine. If someone use PTSD as an example, they don't often sit in isolation on themselves or by themselves. They're surrounded by relationships that might have been there before, the trauma might have developed afterwards, but either way, they have people around them, and it's quite important that we're able to support those people as well as the veteran themselves. We're quite lucky as a service. We do have the ability to complete quite long pieces of work. I've come from different services which haven't got that ability, and I must say it is one of the great things about the CTS, that we don't have to try and see someone and work through everything in a number of months. We might have a lot longer than that if we need to. So that's us again, and I was talking about all the different areas. It looks very small when you view it on a map like that, doesn't it? But we do cover Staffordshire, Shropshire, West Midlands, Birmingham, Solihull, Warwickshire, Worcestershire, Herefordshire, and Black Country as well. Some of those counties, I'm sure some of you will know, are quite rural as well. So there's quite a big mix of people from urban and rural areas, which adds some challenges into the work, but also means we can kind of access all these different population groups. So our team, there are 12 of us, I think, at the moment. I think I might be the 12th person, which is nice. I'm still the new boy, so I'm hoping someone else joins soon, so I don't have to be the new person anymore. But at the moment, our team is made up of, we have the team secretary, who does a great deal of work. And actually, if you were to contact our service, it would probably be Azra who you'd see or speak to, who'd be able to signpost you through to the relevant person. So you have the clinical psychologists, such as Suzanne and I. We have some mental health nurses and some psychiatric nurses as well. We do have a psychological therapist, as well as a small team of stabilisation workers. So stabilisation workers are from various different backgrounds, housing, police, I think, as well. So one of them is. So they're from very different backgrounds. And their role, I guess, being the one on that list, which I find a little bit harder to place in my mind, their role is to offer that initial support, but also ongoing stabilisation work, which Suzanne will come on to in a little bit about what that means. But they're there alongside the veterans throughout their time with the service, and they offer, I guess, not only mental health support, but also some of that practical support, which Suzanne mentioned, around housing problems or social issues, which they may need some further support with. And I think we're back to you, Suzanne.
Okay, so the function of the NHS is to support veterans who have a military attributable mental health difficulty, and that is really the one sole kind of inclusion exclusion criteria. So we're thinking about mental health in terms of something where the military has played a role in this. That doesn't necessarily mean that it has to be post-traumatic stress disorder, but it has to have that kind of element of the military experiences impacting on your mental health in some way or another. So as a service, on the next slide, we'll have a look at more of the idea of like the stage model, but we're able to provide support with stabilisation. And what we mean by stabilisation is more about helping people to get a bit of a stable ground in terms of their mental health. So stabilisation can be around things like, managing moods, managing emotions. It may be about getting an understanding of what's happening to somebody. It can be around, support around housing. It can be support around finances for some people. It may be about building up a social support system. For other people, it may be about developing coping strategies such as relaxation techniques or breathing. It may be about helping people understand some of the factors that are currently making their mental health get worse. So stabilisation is something that I think runs throughout somebody's treatment with us, and it's something that we categorise by itself sometimes, but actually it's something that is necessary to build the foundation of mental health on. We might also do some psychological intervention. As you've seen, we have a fair few psychologists on our team that are trained in a variety of different therapeutic approaches, including cognitive behavioural therapy, where we're looking at how we change the way that we think and feel and the way that we act, as well as kind of more specific ones such as EMDR, which is a treatment that's used around PTSD, or some things like compassion-focused therapeutic approaches, where we're looking at how you change your relationship with yourself and the difficulties that you're experiencing. And a large part of our work often is around things like reintegration and reconnection. So often, quite a lot of veterans will come out of the military, which is considered to be a big family. It's a culture, it's a system all by itself, and that sense of kind of lack of identity sometimes coming out of that in terms of who you are. Obviously you've lost, you know, the job role that you used to do before, but quite a lot of social support can disappear along with that as well. So we might do large pieces of work with people on reconnection and reintegration, where we're looking at kind of building up activities, building up meaningful things in people's lives, helping them to feel connected with the people around them, building up kind of social support systems for people. As Joe said earlier, then we try and see clients closer to the home. So we were initially set up deliberately at the Barbary because it was opposite the QE. So we knew that it was familiar to most veterans, you know, those unfortunate enough to need to go to hospital. There's a veteran centre over at the QE. But equally, it's also in the centre of Birmingham, which means that it's quite attractive, quite a fair amount of veterans considering our wide geographical area, but then also give them the mental health difficulties that people have. We don't expect them to have to come there. So what we try and do is we try and see people where they feel comfortable. So for a lot of people, that might be their GP surgeries. For some people, it may be a local mental health setting. So for example, I've seen clients at Fuller House in Telford, where quite a lot of other NHS services are based as well. For some people, we might meet them at kind of local community centres if we can get a room there. We try to be really flexible, thinking about the client's individual needs, but then also what feels most comfortable, because at the end of the day, if you do not feel comfortable, you're not going to feel comfortable sharing anything with us, and that's going to make it so much harder for us to be able to help you meet your treatment goals. We deliver our service in line with the Armed Forces Covenant, and we attend the Shropshire Covenant meetings where we meet with other mental health providers in the area, other veteran providers in the area, thinking about how we can link up care to be able to help support people along their entire treatment pathway. Bearing in mind, as we said earlier, it might involve a fair few agencies based upon what the difficulties are that you're having. Next slide, Joe. So this is the kind of pathway that we have in mind for veterans when they're coming in. So TILS is very much the gatekeeper. So in order to get to the complex treatment service, then a veteran would need to be referred to TILS, and TILS would make a referral over to the complex treatment service. And from there, what we do is we meet with an individual and we have a little bit of look at the difficulties that they're facing, but then also working out a plan of treatment with them. So for some people, that might be they go straight into stabilisation. So we might assign them a stabilisation worker who can sit alongside them, help them out with some of the environmental difficulties such as housing or looking for jobs. It may be that we do a piece of work with somebody here around managing things like anxiety. So if they're housebound and they're not able to leave the house at the moment, which a few of us are with COVID, and I don't think it's done a lot of favour for many people with anxiety, but they may be able to actually go with somebody from their house to their local area and back again. As I said, stabilisation can mean so many different things in terms of being able to stabilise somebody's mood, stabilise their mental health, but then also stabilise some of the environmental things that are going on around somebody. And for some people, they may only come in for that piece of work. So they may only do some stabilisation with us, and actually at that point, if they met their treatment needs, then they might be discharged from our service. For some people, they may go on and do a piece of work, particularly if they've got post-traumatic stress disorder, on trauma. So that might be something like a piece of work on their nightmares. It might be looking at the trauma itself or trying to work through that through treatments such as EMDR or trauma-focused cognitive behavioural therapy, where we're trying to break down some of the different things that happened in those traumatic experiences and help people's brains kind of understand them in a different way so that they don't continue to affect people on a day-to-day basis in the way that they are doing at the moment. For some people, what they might do is take a break between doing a bit of stabilisation work, and they might come back to us later on for a piece of trauma work. And as I said previously, the third piece of work might be about reintegration. So that might be about helping build somebody's life around meaningful activities and things that really build up their quality of life. And that might be done as a single piece of work. So I've had clients come in and we've done a bit of work on identity that feels quite lost when they've left the military. And so we've looked at, what their interests are, what their values are, and building a life based around that. And then at the end of that, then somebody might be discharged from our service. People can re-refer at any time, again, using TILs, and they can make a referral back through to the CTS. Next slide, Jo. Okay. So from this point, I think it's kind of makes sense to go through what the referral process is. So to access any services, you're going through NHS TILs, and that can be done directly, so you can contact them yourselves, or it can be done by asking a GP or a mental health professional or a military charity to refer you. As we said earlier, ours is the Midlands or East of England, so we've got a phone number there in the email for them as well. The criteria for being able to access is purely that you're either transitioning from currently being in the military and you've got a discharge date, or that you are a veteran, so you've done at least, I think it's 10 days service for TILs. In order to prove this, they will ask for a copy of your service number. Again, this is just ensuring that you're getting the service that you need at the end of the day. Next slide, Jo. And what will happen is a member of TILs will offer you initial assessment within 2 weeks, and where appropriate, a first clinical appointment 2 weeks after that. Now, given that we're in COVID at the moment, it has placed some restrictions on face-to-face contact. So in terms of all the contact that ourselves and TILs have been doing, this might be through a telephone appointment, it might be through a video appointment, like the one that we're through Zoom or a similar platform like this, or it might be a face-to-face appointment. If we are seeing people face-to-face, then at the moment, based upon our current guidelines, people are asked to wear masks, and as NHS staff, we have to wear masks, even if you're demonstrating no signs of COVID-19. It's just one of the provisions that the NHS has put in to try to prevent everybody going into quarantine all the time, so that we're able to provide the service that we're able to. So they are able to offer these assessments and these appointments in a way that feels most comfortable for you. You can bring along another person to that appointment, that's not an issue. We can meet you at GP surgery, we were doing home visits as well. As we said previously, it's all about trying to find a way of going through that initial appointment in a way that's comfortable for you. At the assessment, you will be asked about what you'd like support with, and they'll use that to develop a plan with you. And when we say with you, what we mean is, discussing what the different difficulties are, giving you their advice or where they would signpost you to. But equally, you're very much in the driving seat. If you're not interested, you can say no. If you've been through some of these organisations before, we encourage you to let us know. We're always interested to find out about what your experiences have been in the help that you received so far, and what some of the difficulties and the barriers have been. And where possible, we try and help to break down some of those barriers so that people get the help that they need when they need it. The other thing I think it's worth mentioning in terms of all of this is when these services are not necessarily designed as crisis services, so we're looking at people's long-term mental health and well-being. If it is that a veteran or you yourself are going through a crisis, our advice always as a first point of call is to phone your local crisis team, or to go to A&E, or to phone 999. And I can assure you, this is one of the things that people always find slightly controversial and slightly difficult, but the ambulance services would far be happier going out and visiting somebody if they're experiencing suicidal thoughts or thoughts of harming themselves, than they would not having that phone call. All right.